Hi, this is Piyush Bhargava and you're watching the F18 sodium fluoride bone PET-CT teaching file. Let's quickly review the protocol that we use to do this study. The indication being evaluate patients who are suspected of having bone metastases or patients who already have bone metastases and they're undergoing treatment to follow up the status of their bone metastases. The radiopharmaceutical is 10 millicuries of F18 sodium fluoride, which is injected IV, and 60 minutes later, whole body images are acquired from top of the head to the tips of the toes in a 3D mode, and iterative reconstruction algorithms are used to process the data, and the CT, which is acquired as a low dose CT for anatomical localization and attenuation correction, is used as well. So F18 is a positron emitter. It has a half-life of 110 minutes. The positron undergoes an annihilation reaction and produces two 511 keV photons, which are detected 180 degrees apart, and they are counted as a true event when captured in a narrow time window of 9 to 12 nanoseconds in two detectors 180 degrees apart inside the PET scanner. The mechanism of uptake of this radiopharmaceutical is blood flow and osteoblastic activity, just like technetium 99M MDP or HDP. Physiologic uptake is seen in the bones. There is excretion of the tracer from the kidneys into the urinary bladder, and there is faint soft tissue activity. The critical organ for this radiopharmaceutical is the urinary bladder. Let's look at a normal F18 sodium fluoride bone PET-CT as a rotating MIP image. There is uniform uptake in the spine, although slightly heterogeneous, but there is no focal uptake to suggest osteoblastic bone metastases. There is symmetric uptake seen in the ribs, bones of the upper extremities, skull, pelvis, and the lower extremities. There is excretion of the tracer from the kidneys into the bladder. There is very faint soft tissue activity. So that's the rotating image from a normal F18 sodium fluoride PET. The way to differentiate it, if you're finding it hard to differentiate this from a FDG PET-CT scan, whole body MIP image, is to look at the brain. FDG is taken up intensely in the brain, but sodium fluoride is not. Sodium fluoride is a bone tracer, and this almost looks like you can call it a 3D bone scan. This comes with a low-dose CT, which is used for anatomical localization. We'll take a look at some images later. Now let's take a look at a positive F18 sodium fluoride bone PET for osteoblastic bone metastases. So here we have a rotating MIP image showing multiple scattered foci of intense uptake involving the axial skeleton, the skull, the spine, ribs, scapula, sternum, pelvis, and bilateral proximal femur. Remember, osteoblastic or bone metastases are typically seen in axial skeleton, and they go to wherever there is active marrow. In an adult, active marrow is seen in the skull, spine, ribs, and proximal aspect of the upper and lower extremities. So that's where we predominantly see bone metastases. Certain cancers produce osteoblastic bone metastases for which sodium fluoride is used, such as prostate cancer, lung cancer, breast cancer. Other cancers produce osteolytic metastases such as renal cell cancer and thyroid cancer, multiple myeloma. Those are the cancers for which F18 sodium fluoride PET-CT is not going to do that well. So this patient has disseminated osteoblastic bone metastases in their axial skeleton. So let's look at a fused or coronal images from the same study. And here we have a coronal PET image on the left and the corresponding CT image on the right. And you can see that this focus here of osteoblastic bone metastases corresponds to a sclerotic lesion. So most of the times that's what you're going to find, some morphological abnormality, but don't be surprised if there is no morphological abnormality on the CT, because we know that a lot of times we see these lesions on functional imaging such as a bone scan or sodium fluoride PET-CT earlier than any morphological changes on the CT. So this is showing the correspondence of osteoblastic activity with sclerotic bone metastases. Case number 3 is showing a interesting sodium fluoride bone PET-CT in a patient with renal cell cancer. The rotating image shows a large focus in one of the ribs here, another smaller focus in one of the ribs right there. Two additional foci in the ribs, multiple foci in the pelvis seen here, here, and here in the ischium. And more inferiorly, there's a focus in the right foot. So let's look at it in a little bit more detail. So these images are showing the right calcaneus on the CT bone windows, the PET image, the fused PET CT image, and the whole body image. There is a large lytic lesion involving the right calcaneus, which shows peripheral intense uptake. Now, as I said earlier, renal cell cancer produces osteolytic bone metastases, and that's what it is. But even at the periphery of these lytic lesions, there is a lot of osteoblastic activity, and that osteoblastic activity will take up the tracer, which is seen here. So a very rare case of lytic bone metastases to the calcaneus from a renal cell cancer. Like I said earlier, bone mets in adults typically go to the proximal aspect of the upper and lower extremities because that's where the active bone marrow ends. But in certain cancers, when patients are anemic, such as lung cancer or renal cell cancer, there is bone marrow expansion. So there is more active marrow in distal extremities, and in that situation, bone metastases can go to distal extremities. So those are some of the patterns and things to know regarding a F18 sodium fluoride bone PET CT. Thanks for watching.